Our next conversation is going to be about particularly our health sector in this country that has benefited a lot from external support. And there are many times where we've said our health sector is actually externally funded. Is that a good thing or is that a bad thing? Where so much, more than 50% of the funds that are used in health are not actually from the exchequer, from our taxpayers, from our taxes, but from support from elsewhere. But one of those institutions and organizations and countries that have really supported our health sector is the U.S. government through what is called the President's Emergency Plan for Aid and Relief, PEPFAR, for many years. And City, you've told us about this because you've interacted with PEPFAR directly.
For many years
years as well.
Yes.
The country coordinator for PEPFAR currently is Brian Rettmann. He is our guest for the next hour. Brian, good morning.
Great, thank you, and happy Thanksgiving.
What's that? Because you've come here with a big animal. What's this?
Yes, so this is a turkey, our traditional dinner that we do on Thanksgiving, and hopefully we'll be able to sample some as we go along the way here. But we have all the fixings as well that the U.S. government has provided for us to be able to partake this morning and really kind of share the traditions that we have for Thanksgiving.
Wait, this thing is huge. It's
big
huge.
Bird.
It's a
big bird.
It's a big bird.
From a big country.
Oh, yes.
Yes.
Why turkey?
Turkey in the fall in the U.S., it's a bird that is really readily available, and it's a big bird, and so it can fill up a whole family. So when we have our family get-togethers, it's usually between 10 and 20 people, and this bird will feed all of them, and usually we'll have extra for days to come.
Okay. And why Thanksgiving? What's Thanksgiving?
So Thanksgiving is again a traditional holiday that really is about harvest. And the myth started about the original colonists coming in and having a difficult time, and the American Indians helping them out and bringing a turkey to their table. Again, that's the myth. We don't know if that actually occurred, but I think it's a good myth. We've went to that, and so we still eat turkey, but there's pumpkin pie, and there's cranberries as well. A lot of really good food, and we have some of that for you here as well.
So there's pumpkins.
Pie, bro, not pumpkin. Pumpkin.
Tunakula malenge, bata mzinga.
Yes.
Hizo vitu leo.
Yeah, the potato mash pia.
Mashed potato, yeah.
Hey, okay. City is going to give you the day's proverb. Every week he goes to an African country. He mines proverbs from that country, and then he brings us a proverb a day. And your job is to listen to the proverb, think, and then tell us what you think the proverb means to you. This week, where are we?
We are in the kingdom of Eswatini, formerly known as Swaziland.
Yes, Swaziland.
Yeah, it was known as Swaziland, but they changed that
To Eswatini.
Yeah, they got 2018, 19th of April 2018.
Did they give a reason?
The reason was they wanted something that resonated with their leaders. They had a king. Kingdoms tend to have kings, okay? Empires tend to have emperors. And democratic institutions and countries tend to have presidents, okay? There was a king in the 19th century called Mswati II. It is him who helped them perhaps consider the mentioning of naming the country Eswatini. Now, the current president is also... it's a problem of democracy. I should just become kingdomized completely.
Totally.
Yes. The current king of this particular kingdom is actually Mswati III. Okay? But they have a long tradition of kings. Long. That region of this particular continent does have it. Right. The proverb. A person who says it cannot be done should not interrupt the person doing it.
Person who says it cannot be done should not interrupt the one doing it.
Yes.
Brian, what's your interpretation?
I think that's an excellent proverb, and quite often, I think as we're going through life and doing the things we do, we have detractors. and we can either take them as naysayers or we can take them as contributors. And I always try to make sure that I consider people as contributors. So as we move along in life, if we just say no, that's never going to work, people are going to stop listening to you. So I do think it's one that it's a really good saying, because as you are progressing, I think you need to understand there's a variety of people out there, and some are going to be for you, some are going to be against you or the things that you're doing. And to me, it's good to listen to everybody, to hear what their different views are, so that you can actually really get a helpful process to that is inclusive of all. But for those ones who really are naysayers and are just naysaying to naysay, you have to recognize who they are and try to work through them.
And say no to them.
Yeah.
In fact, even as I was reading this proverb, it occurred to me that the very topic of discussion revolving around PEPFAR actually gets to the heart of this matter. And this proverb actually represents it very well, because if you look at the PEPFAR program and what it has done, it's something that had someone told you it could do, you would have said, actually, this thing can't actually be done.
Forget about it.
Yeah.
No. And yet it did, and has, and continues to. Yes.
So, Brian, what's PEPFAR for those who've been living under a rock?
So, and I know you guys are knowledgeable about it. So, but there's several folks that are out there who may have what is it? And you gave the acronym, but it's President's Emergency Plan for AIDS Relief. We've been working throughout Africa and really around the world for the last 20 years to address HIV. I've been doing it for longer than that. I started my work in Botswana back in 2000, and the response really has changed, and the epidemic has changed so much because we've had really great success in getting people on treatment and really getting prevention services out there, so that now new younger folks don't even know what HIV used to be in the 90s and 2000s in Africa. So I think it's one that we have programs out there to try to make sure that the 1.37 million people in Kenya who are living with HIV have the services that they need, and that's treatment programs as well as other services. Now what we're looking at is, as mentioned, we've been around for a while, and we're now starting to take a look at how can we work much more sustainably, and instead of having something that's kind of a parallel or not parallel, a system that works outside of the Ministry of Health's public health system. We want to work much more integratedly and trying to ensure that those patients that we have still have the services that they need, but doing it in a much more financially sustainable way.
So 20 years ago, what happened? Well, what led to the decision to found PEPFAR?
It was, and the good news is we have just had bipartisan support from Congress and from all of the presidents that in the last 20 years. And this was started by President George W. Bush. And in 2003, he made an announcement that he was going to put forward $15 billion for AIDS in Africa. And he saw at the time that there was just a huge tragedy and despair that was happening, particularly in southern and eastern Africa. And there were, at the time, I think in Kenya, there were a couple thousand people on treatment. And the treatment was so expensive that no one could afford it. So as we move forward and as we progressed, we now have 1.35 of the 1.37 million people on treatment. And to me, that's an astounding and one of those impossibilities that was actually made possible, and really by trial and error, trying to get things as improved as best as we can. And now it's a matter of how do we ensure that those individuals have the services that they need, and that we have the prevention services as well, that as the new infections have gone down, that we can try to decrease them more and more as we move forward.
So have we seen that there has, looking at, I think it's unbelievable the help that has come to folks because of this funding, and that people then have obviously become dependent on it, because now we see things like, HIV/AIDS medication is not charged to folks who need it. But then, do we see that reduction of this funding over years? Do we see that? And then, if that's the case, what's the reasoning behind the reduction of the funding?
We have reduced, and about 5 years ago we had about $550 million per year, and now we're at about $320 million. So we have reduced over time, but in that same time we've actually increased the number of people on treatment. So a lot of that was finding efficiencies in the system, and we have more efficiencies to gain as we look at how to better integrate into the government's and really the Kenyan people's healthcare system. We have also done that, and I think we're on that trajectory to continue to go down in funding, and so that's led to a lot of discussions with the government and with with PLHIV around what does sustainability look like, and how do we ensure that those services are still available. Partially through government systems, partially through private sector, and partially through some continuing efforts by PEPFAR and Global Fund. We're in those discussions, and we have World AIDS Day coming up in just a few days on Sunday, and I'd like to invite everyone to come out and do the marathon or half marathon at the stadium. But it's one that at that we're going to have an announcement from the government on sustainability operational plan that they've been pulling together that really talks about how that integration will happen, and we want to continue to be helpful, but the reality is, funds have been going down, and we want to make sure, above all, that patients have the services that they need, and we want to do that in a way that's respectful as well as really efficient.
2003, 2023, 20 years down the line, the process of ensuring that the government started off as the national government, and then the county system came into Kenya, getting the county governments to actually own the process and to be able to cater for the needs of those who had tested and who were under treatment. How has that process fared, and what are the things that were done, and what are the lessons learned in those processes?
It's meant that instead of having one relationship with U.S. government and Ministry of Health, we've had relationships with each of the counties, and so we've worked with our implementing partners, and as we move forward, I think there's going to be a lot more of those relationships county by county. And the challenging thing is each county has a very different epidemic. You have Homa Bay, which has the highest prevalence rate in the country at around 16%, and then you have some of the Azo counties, which are less than 1% or less than 0.1% of prevalence. And so each one of those have very different responses that need to work. And so we're trying to now have those discussions really county by county to determine what is the best possible method or mode of intervention for them. And so those models of care we're going to build up over time. And as we look at these transitions, it's not something we're going to turn a light bulb. It's something that we have to work with over a couple of years to make sure that those are working well. And again, so that the patient's care doesn't. It may change, but it may not. We want the quality of care to increase and not decrease during that process.
A lot of work has been done in capacity building over the years. Now, I'm speaking as somebody who worked in that particular field for close to 2 decades. And the thing that I have always found daunting is, now I am actually probably going to be a little off script here, the resistance to accepting that the responsibility of caring for those under treatment should be that of the government, national and county. It has, that, in my opinion, that reluctance has actually hampered the process that PEPFAR was seeking to achieve. Why do I say this? 20 years of funding. You're talking about some many billions of Kenya shillings. That is enough time for capacity to have been built and people to have understood what needs doing, so that all that was required was, as I said, just a little nudge from there to there. But yet, there is the issue of dependency that still takes center stage when it comes to matters of HIV.
Yep. And across health and across all of the development sector, really. And so I think that as we're looking at this, it's one that we really need to define the way that the Kenyan people want that response to look like. And as we do that, as we work with governments, especially county governments more, we're more closely defining the number of people that we're employing, the doctors, nurses, community healthcare workers, so that they understand what that looks like, and so that they can now budget in 4 or 5 years to come on how they can take that on. There's a challenge right now. There's a cash crunch in country. And so I don't think we can just, again, turn a light switch and say, okay, it's yours to take care of. But it is one that we want to make sure that as we are transitioning or transforming the way that we do work, that those county governments really understand how we're doing it, how much that it is, and that we can work with them to better budget in the future, so that it's there. We can then also work with the national government and with Treasury to ensure that when the county's asking for funds as part of their budgeting process, that they actually deliver. Because I think some of the challenge we faced is we went from the 550 million to 320. We've asked the government to take some things on, particularly with commodities, and there's quite often been unfulfilled commitments there, and we want to make sure that as we are working smartly to have that transformation take place, that we're not, I'll say, in the words of our unfortunate turkey here, stretching our necks out too far. Because I also, there's an American proverb that I can bring in that's "Don't count your chickens before they hatch," and we want to make sure that we're really doing that soundly and not just, again, saying, okay, here you go, it's all yours. But the first step of that really is the question that we've been asking over this last year of what does Kenya and what does the Kenyan people and the PLHIV who are living in Kenya want the program to look like in 5 years? And then we can start changing our programming so that we can get there.
Our conversation continues with Brian Rettmann, Country Coordinator for PEPFAR, supporting Kenya's healthcare for the last 20 years. So, Brian, how much in those 20 years?
So in the last 20 years, the PEPFAR has been allocated about $8 billion US, which I don't have my math in the head, but you do 125 times that, and it's a healthy amount. Yep. So
good money.
The second part of your question is, what have we spent that on? And when we look at our annual spends, about a quarter of the money, a quarter to half, is spent on healthcare workers, on their salaries and ensuring that they're in place. Another healthy part of that, between a quarter and a third, is commodities. So ensuring that we have ARVs and test kits and lab supplies in country. There's additional other services that we provide that are health services in terms of building the strategic information systems and the electronic medical record systems in facilities, in terms of building labs and ensuring that those are there, and other systems work. The good news about that systems work is when we are encountering other diseases such as Mpox, such as COVID, such as Marburg that they're having in Rwanda, that systems work actually is there and can be used across the different disease platforms. And so it's been helpful not just for HIV, but building a surveillance system that really works and really builds a global health security platform has, I think, been another feather in our cap. roadmap to really say, when COVID hit here and really across Africa, it was much less than what occurred in even some of the Western countries, even in the U.S. And part of that was because we had such good surveillance systems built up because of the work that we're doing in HIV.
So if you talk about it, so a lot of it has gone into recurrent, paying salaries, buying consumables, and then there's a bit of it that's gone into development of infrastructure, like the health. How much would you say has gone into the development side?
In the development side, generally around 20 to 30%, I'd say. That's just a figure off the top of my head, but I think that's probably a good estimate. Because when we're looking at the lab systems and the SI systems, we just in the last few years, we went from paper-based systems to electronic medical records, and that was it was a huge endeavor, and we were just doing that within what the government was calling the HIV corner of the facility. But what we learned from that is that those electronic medical records are really useful to be able to not just have within the HIV world, but for patients to be able to go across to the other parts of the facilities. And so as the government has been rolling out their UHC platform, they've asked us to extend that EMR to the full facility where we're working. And we've done so in about 100 facilities, but the plan is to have that rolled out to about 2,400 facilities. The government has actually put in and working with some other partners to get the actual computers and tablets in place while we've been working with training people on the software. But that now is then able to be used for really just a wealth of information, because you can really do true surveillance when you've got that information. Now, I want to make sure that it's clear that when that information is pulled out from the facility, that is de-identified, so that you can't say, Eric, this was your medical record.
It's completely anonymized.
But it's anonymized, so that. But we do have a unique identifier, so that we can tell when a patient is going from this facility to that facility.
How much of that development has actually gone local? In terms of, even as we're developing the information system, is it locals that are getting to do it? When you're talking about supplying of test kits, have we built the local capacity, for example, for us to be able to build those test kits, for us to be able to even have pharmaceuticals that can manufacture the ARVs locally?
Yep, we actually have, and the good news is we've actually worked with a couple different companies, manufacturing companies in country. The one that when we did the state visit in May, Revital from Khalifi, they are now producing their own HIV test kit that is a rapid test kit that can be used. They're trying to get the WHO pre-qualification so that countries can buy it, but it's one that's a good quality test that's being made here in Kenya, and it's the first, I think, African manufactured and produced test kit. So I think it's and USAID, one of our agencies under PEPFAR, did help them out to try to make sure that they had that manufacturing base to be able to work. We'd also work with some of the other local firms like Universal, who produce pharmaceuticals, and I know that they do produce some ARVs as well that are already on the market, and that are procured through our processes. So yes. Can we do more? Yes. And I think we've just really started the discussion around regional and local manufacturing and how we can make sure to remove some of the hurdles. Because like I said, for Revital, they have that test kit, but when the country, when each country really does its when it sets what its algorithm is for the test kits, it's usually done every 5 years or so. And so you can have the test kit on the market, but if nobody's changed their algorithm, you've got no buyers for it. So it's really trying to figure out how to change some of those processes to make sure that if there is a local product, that we can try to prioritize it as best as possible.
I mean, it's just, even when you look at the support that comes to for HIV and AIDS, and just looking at what has been done over the years, the elements of then dependency of one nation to another comes into play. I mean, heavily, that conversation, however you want to look at it, is front and center. And I remember a couple of years ago when there was the issue of, help with the whole blood banks and where the conversation went when Kenya was being asked to look, in another 5 years, we're going to reduce the funding. Mm-hmm. In another 4 years, it's going to be reduced. So start thinking about ways in which you can become independent of this kind of funding. Is that the eventual goal? There's an element of dependence that plays. I mean, I don't think it's even an element. I think it's full throttle dependence.
Very much so, yeah.
That now, today, if that funding were to go away, the thousands of patients who need it then for their medication essentially would have nothing. But then there's also the call that comes on nations and governments to be able to do something for their people. Where does all of that play?
It really truly comes to play substantially. So as we are having those discussions that I mentioned around sustainability, we need to ensure that we're learning from some of our past, I'll say, missteps. And the transition of the blood transfusion program is one that I think we have some lessons to learn from. But the reality is there is a mindset, I'll call it mindset within Treasury and within Parliament. When we've come to talk about transitioning and trying to bring on more, Ministry of Health may be on board, but if the money isn't there, then it doesn't happen. And and we have to make sure, and some of the mindset that we've faced is, that's donor funded, so we don't have to take care of it. And the reality is it's donor funded now. It may not be donor funded in 5 years or 10 years. And so what we need to do right now is try to transform ourselves to put ourselves in a place where it can be funded locally, either through government or private sector or insurance. But it's one that we need to make sure that we're setting the stage now to be able to have that happen, because I can't prognosticate where we're going to be funding wise in 5 years, but I can say that it's likely to continue to go down for PEPFAR annual funding, probably, and I don't know what trajectory that looks like, but it is one that we need to plan for it to go down so that we can change that mindset. And some of that's going to be just going on road shows and us talking to parliamentarians and the Treasury. Part of it is really kind of understanding better that, especially as Kenya has moved forward in its development and as it goes to lower middle income status, that the expectation is that it can pay for more things itself. It's a unfortunate, harsh reality of progressing into the future. But it's one that we want to work with you on, because again, we don't want to just turn lights off and say, all yours, because there's 1.37 million people that are relying on us, and we want to do that in a way that's really responsible.
Taking all things into consideration, what does a healthy, sustained transition look like? Where you say you understand, even if it's economic issues that a nation might be having, vis-a-vis, decision making, and then saying here is an element of support which is coming from a federal government. How do you have a transitional operation with all of those elements taken into consideration?
It's a complex, overall process. And the first step is what I was talking about earlier, and changing the way we do things. And part of that is really making sure that the services, as we've set up in those 2,400 clinics that I talked about, there are patients who have been on treatment for multiple years. Their viral load has gone down to zero, and they actually don't need to see their doctors more than twice a year. In those instances where somebody's really stable like that, we can start taking them away from the large volume facilities and have them seen by a doctor that's at a lower level facility, because it's a lower level of care that's really needed. Now, if they rebound or come back in with a higher viral load, can push them back up again. But it's one that those services then can be closer to where the patient lives, so they have less of a challenge. They can go to the doctor fewer times. We can also try to make sure that we're setting up pharmacies that they can pick up their drugs more regularly close to them if they want to. Again, there's still some stigma out there and so people may not want to pick up things that are close to their house or close to their business. But so we want to give them the options that are available. Now, as we move that forward and have that transition, that will hopefully make things a little bit more cheaper. I shouldn't say cheaper. Make it less expensive.
More affordable.
Because I don't want to have the mindset that it's lesser. But yeah, more affordable is a better way to say it. And then we can continue to discuss that with county governments, but they can't just manufacture money. They will have to have that coming from the Treasury or from the Shah. And one big element as the Shah was being developed was whether or not HIV was going to be included. And they've included a few elements, particularly for pediatrics, but not for a broader set. They have said that in the future that they will. But promises. So I want to make sure we hold them to that. But I do think between private sector, one that we haven't really done here. We did a study a few years ago that said that about a quarter of those PLHIV who are on treatment are willing to pay for the services at least a little bit themselves. And so I think as we look at different elements, we can work with private sector facilities to provide some of those services themselves at a nominal cost, and we might subsidize it a little bit on the way to try to make sure that there's another option for individuals to go to. So it's building those options, building up the capacity of people to have funding come in. But in the end, we will need the government to increase their expenditures year to year.
In the end, we will need. Have we seen that happening?
We have seen commitments.
Have you actually seen the budgetary allocations to health increasing in the last 20 years, not just in tandem with the revenue growth, but in tandem with actually what's needed to be done?
I think I could be wrong on this because I remember seeing figures, but overall it has per capita and the spending for health has gone down marginally. So they're trying to keep on pace. One of the challenges is the debt situation here, where the amount of debt that is paid off of as part of the budget has increased substantially over the last 2 years, and has made it just that much more difficult for the government to find that money. I think the money's still there, and I think it particularly, as I was talking about the EMR, that when that is linked to, again, across the full facility, if that is linked to social health insurance, it draws down the possibility for corruption to come into the system, because there's a much better electronic records to be able to say, okay, this person actually had those services. So I'm hopeful that some resources can be found through that. But people are creative, so I think we have to make sure that those fiduciary agents are in place to be able to figure out where that is occurring and where there's new, I'll say, entrepreneurial folks coming into play.
Over the years, Brian, you've worked across the continent in the development space, right? And you've seen development support going to governments for critical sectors of their economies, like now in this case, health. Crucial, critical. Do you see governments developing a sense of dependency and just getting used to this money that's coming in, so they don't think about where else they can get the money, so they just expect that they'll be supported?
We definitely have seen it, over the last 20 years, and that I've been working in across Africa. Actually, 25 years. Sorry, I've lost track of time. But yeah, you see it, and it is a challenge that you face. That as you try to deliver systems that work. there is a mindset that money is always going to be there and that financing is always going to be there. And we really do need to come to the understanding that as you progress in your development, that it's time to take some on. But part of that is also there was a bit of mysticism around what PEPFAR was doing, and in terms of the number of doctors that we had out there, the number of nurses, et cetera. And really, part of that was our work through implementing partners rather than through the government. Some of that will shift as well as we move forward with those counties so that there will be more funds going to them. But as I mentioned, as we do that, we need to make sure that the financial oversight is in place to ensure that those shillings are spent in the most efficient way.
There's one school of thought, one argument that says those in government have become lazy because there's free money coming in and it's just going to support and doing the work that government should be doing. So they turn a blind eye to that and they're like, okay, that's being sorted. Let's focus on something else. One side. The other side is that the development agencies such as yourselves are actually using that tool as a power tool. That you want to make sure that you are coming in and supporting through your agencies and others, and also frustrating any effort by the local governments whenever they start coming up with anything that looks like, they want to gain control and start getting independent. That it's a power tool as well.
Sure.
That you can argue that it's not the Kenyan government that refused to think beyond those 20 years. It's the Americans that did not want us to move. How do you respond?
What I'll say is, when we talked about PEPFAR, the second word in PEPFAR was emergency. And so as we first rolled out, we were trying to deal with emergency, and in most countries where we worked, the healthcare system was either non-existent or not capable of doing what we wanted to do. And so we set up a parallel system that was kind of our own, and that kind of led to that mentality of, okay, that's them over there. As we move forward in time, we tried to be more integrated. And so like 2011, 2012, we tried to integrate more with the national healthcare systems. And that led to better interactions, but there's still that mindset that PEPFAR is going to continue. And PEPFAR should continue. Don't get me wrong. But I do think it's one that as we move forward and, we've reached the 20-year marker, we're now looking at, okay, what does the 25-year marker and the 30-year marker look like for each of our interactions in countries? And there's some countries that are not really going to be able to take on the efforts that we do. But we are changing from that emergency mindset that we started from to one that's more chronic care, that can be much more integrated and doesn't require that kind of high level of intensity in delivery. So it's one that, as we change that mindset, we're hoping to kind of move away from it. But
Whose
I will say,
mindset are you changing, Brian?
Our
Is it
own,
the mindset of
our own, and people living with HIV
partners.
and other development partners and the government. So it's really all of ours that we have to change.
Do you think this will happen? A mindset where a development partner comes into place and from the very beginning integrates with the government and its programs and supports the government and its programs, instead of what we see, development partners come into a community and they set up their own parallel thing that they're running because, you have all these reasons. The structures are non-existent, they're not capable of absorbing our money, so we'll set up this thing on the side and we move on, and then after 5 years you leave.
Yes.
And you leave a government that was not involved in this thing, and that thing collapses.
And may not have even wanted what you were providing.
Exactly.
So I think that, as we're doing that with PEPFAR, and PEPFAR is one of the largest donor programs around. And as we do that with PEPFAR, I think the mindset with other donor partners, as we work with development partners in health, is changing as well. And so I'm hopeful to be there. I don't want to count my chickens before they hatch, though. So, as I mentioned. So, but I do think it's one that we have to change that. And I think as we are all learning, to be better global citizens and citizens of where we live and work, we need to understand that. So I'm hopeful to be able to do that. I think we've got a pathway through this sustainability operational plan that the government is actually putting forward, that we're listening to, that we didn't say this is what needs to be in it. I think we're going to get there. But I do think it's one that is going to involve a lot of discussing with us, with our partners, with the people we serve, and with the government to really understand how to do that in a way that is, again, respectful and really kind of works towards the patient as best we can.
Is this process that you have just explained very, very clearly, is it part of the process of engaging directly, say for instance, with the county government, as opposed to engaging with the county government via a partner that I think your government's policies necessitated a partnership that had to involve a U.S. institution. So now, if we talk about the changes, are we seeing direct involvement with the county government? And if that is so, what's that looking like?
So currently, with PEPFAR, we have various agencies that do work in Kenya. One is USAID, one is United States Agency for International Development, one is the Centers for Disease Control, one is the Department of Defense, and then Peace Corps also has some work as well. And the work particularly and each one of those agencies have had different processes as we've moved forward. So CDC has actually, from the start, worked with more local implementing partners than the other agencies have. USAID, about 5-6 years ago, took on the mantle to have more local partners doing the work, and really transitioned from about 30% local partners to 100% local partners, and not always to the best outcomes. However, we are continuing to work with them, but now the transition that we have to look at is how do we go from those implementing partners to something that's more government to government. CDC has already started that and has been working with 13 or 14 different county governments to build a relationship in a small way. That it started in a small way. And we have to start in a small way to ensure that we build, again, that financial infrastructure, that there's a clear understanding that if we succeed in this, it's a great pathway for government to be able to take more of this on in the future. If we don't succeed in this and there's suddenly money going astray, that our true test is always if something hits the headlines of the New York Times, and in a bad way, it's usually a bad thing, and that's when we have to start really revising. The good news is, and coming back to Revital, the first time in my career I've worked on something that went into the New York Times that was a good thing. And the story about Revital was there in New York Times after the state visit. So, but I do think that's one that we really do need to try to make sure that we're working towards a financial, stable, and really financially insured process that would go through the government across all of the counties where we work. And we're trying to do that kidogo.
Brian,
but
would you
really
say the
stable.
focus of PEPFAR is to forward and promote a curative process that involves just that, or are you also working on the preventative side of care?
So we work on both sides. It's not curative, but it's treatment, because we don't have a cure yet, but we do have a treatment, and that treatment is really, really successful, patient by patient. We've seen that for those patients that are taking the particular TLD, is the tenofovir based drugs, they have about 90 to 95% success in achieving viral suppression. And so we want to make sure that that's there. There have been a handful, like 7 or 8 cases where they've been able to do cures based on some blood transfusions, but there were patients that had another issue, had these transfusions, and had multiple transfusions, and then were able to be free of HIV. That's not going to work for every patient, nor is it really financially capable for us to do so, because we're talking about that was hundreds of thousands for each of those patients. What we do want to make sure is that we have, as we progress, and if they do find a cure, if they do find a vaccine, the moniker that we always heard was the vaccine is 10 years away, and we're still hearing that. So I'm not holding out hope until that comes, but I do think it's one that, on the prevention side, we've been working very closely to provide all of the populations who are most really at risk, and that's adolescent girls, young women, men. We need to get men to actually come in and see the doctors, which is a huge challenge. But the key populations, fisher folk, are all ones that are really at heightened risk, and we work with those and people in prison as well, and so we work with those populations. And there's a pre-exposure prophylaxis (PrEP) that currently is in pill form in country, but on the horizon we have the injectable that's coming, Cab-LA. Hopefully within the next year it should be coming into country, and that one is a one injection every 3 months that I think is going to be really helpful. There's another one that's even farther on the horizon, lenacapavir, that is one injection every 6 months. That is really hugely protective. So that's on the kind of medical side of prevention and curative. We also do a lot of programs like our Dreams program, working with adolescent girls and young women, who where we provide a much more layered approach to try to keep them in school, try to get them jobs so that they don't have to resort to commercial sex or transactional sex, and several other programs within that to really try to make sure that they're there. We've done those in a handful of counties because because it's that layered approach. It's been rather expensive per person, but it's been really effective per person. As we move forward, what we need to do is learn what are the most successful elements of that, and I think the key to it really is education. Try to make sure that girls stay in school is a really critical piece, because once they stay in school, they learn about themselves. Yep. They learn about the outside world, and they have better employment outcomes as they move forward. So to me, that's a critical element that we need to work on to make it more sustainable, because that's one that we can't really afford in the long run. But it's been critically important to try to make sure that we get those new infections cut down substantially.
Brian, we thank you very much for coming, and thank you for bringing the turkey. Now we are going to serve the turkey and devour the turkey. And then there's some more for our colleagues as well in the KTN and the Standard Newsroom as well. Brian Rettmann is the country coordinator for the U.S. President's Emergency Plan for Aid and Relief, PEPFAR. He's been our guest, telling us about the PEPFAR and how it has supported Kenya's healthcare system for the last 20 years. And also he brought us a Thanksgiving turkey. Have a lovely weekend as we devour turkey. Enjoy yourselves. Remember, go to Woolworths, buy 3, pay for 2, get 1 free.
Yes.
All right. 2 minutes after 10.
Can I put one more plug in?
One more.
For World AIDS Day, come on out to the stadium. And if you want to sign up for the marathon, it's WAD24.nsdcc.go.ke. And come on out.
WAD24.nsdcc.go.ke.
This is the Situation Room, the only way to start your day.